And we are live. Okay, well, I would like to welcome Tyler Hastings today, and he has agreed to talk to us about treatment outcome measurement. And we've sort of been investigating different things on this podcast related to functional testing. And so, I'll just start with a really sort of simple thing, Tyler. Like how did you end up getting here today? Like, what's the journey that took you to get to here?
Well, that's a great question, actually. My gosh. I think that probably started off when I was about 14, 15 years old. I was backpedaling in gym class without good shoes on, broke my wrist, and then ended up getting my first fracture. That led me to my first experience with physiotherapy. I had no idea that that profession was even a thing at the time. So it was the first time I heard about it. It was the first time I actually met a physiotherapist and kind of learned about what they did from a purely orthopedic standpoint. And from then on out, I didn't really know what I wanted to do at the end of high school, but I knew that they had this crazy new class they were trying out called exercise science that was taught by my gym teacher, who was a Western grad. Realized that I was really good at memorizing the anatomy, and then that led me to my kin degree at Western, and then struggling to figure out what I really wanted to do as an undergrad student. I feel like that's a pretty common experience, but had a great chat with a professor. I do believe he's still the dean of health or kinesiology at Western University right now, Dave Humphreys. He sat me down in his office and chatted me up about, what my interests were. And then that led me to, deciding in my fourth year of Western kin to apply to physiotherapy at Western, Mac, and U of T. And then I got the acceptance letter from McMaster University in 2019. And then I did my schooling there. When I got home, interestingly enough, one of my classmates from McMaster used to volunteer and work as a physio assistant at my current job. And they posted a listing for new physio residents, and I applied, and they offered me the job the next week. And here I am 3 years later.
Okay. And do you want to give a shout out to the clinic that you're at today?
Oh yeah, 100% new physio rehabilitation, north and south locations in London, Ontario.
Okay. And what does sort of an average day look like for you there?
Well, average day currently, I'm working with third placement physiotherapy students from Western. So an average day for me, I'm usually just kind of waking up in the morning, kind of looking through my notes, looking through my charts, seeing what my plan is for the day, what I'm going to be delegating to my students, and she's got increased responsibilities being in an advanced placement. And I go through typically on Mondays and Fridays are my mornings, so I see my clients first, and then I'll go through, do some charting, look at some reports. That's where I do a little bit more review of outcome measures. So we see a whole mix of patients from private to MBA to WSIB and to other emerging technologies, including PONS through the there's a randomized control trial that we're currently working with. And we also see private patients who are engaging in PONS rehabilitation. So that's usually where I'm looking through outcome measures, analyzing my findings, updating my plans, updating my charts, updating my home exercises, etc.
Okay. And what type of patient, if I could ask that question, like what kind of patients do you prefer to treat?
Oh gosh. Prefer?
Yeah.
I don't know if I would say prefer. I would say me personally, I enjoy the challenge, which is probably the main reason why I wanted to go to New Physio in particular. There was a lot of other places in the city. The one thing that I was afraid of when I first started working as a physio resident was losing kind of the experience in different areas of competency. So the neurological, the cardiovascular, and the orthopedic. New Physio offered the biggest balance between those three because it's a bit more of a clinic that has a special interest in neurological populations. So I'll see anybody from a 6-year-old with maybe a prepatellar bursitis or jumper's knee with a young teenager to a 94-year-old who has late stage Parkinson's or stroke or spinal cord injury, etc. I see everybody from young pediatrics to older individuals from basic orthopedic conditions like lateral ankle sprains to more complex presentations like multiple orthopedic traumas and traumatic brain injuries from car accidents. So if there's one thing that new physio has taught me more than anything, it's to be comfortable in the gray area and to be comfortable in the more complex situations. So if you asked me when I first started physio school, I probably would have said something along the lines of orthopedics and sport medicine, around that kind of area. Now, I don't think I have a preference anymore, if I'm being honest. I'm also the worst person to ask that question too. I'm awful at picking preferences.
Alrighty. And so there's not a preferred type of patient that you're looking at. Is there a preferred behavior that a patient has that you enjoy working with? Like, is there something you could tell us about a patient's behavior? I really like it when my patients do X.
Oh, that's a good question. I think my favorite kind of characteristic, or I would say a characteristic that I think bodes well in terms of recovery or prognosis, is I would say just good open communication. So good open feedback. If I delegate an exercise to a physio assistant, or if I prescribe a home exercise to a patient, one of the things that I always tell them is give me feedback. I need feedback, because if that exercise reproduces symptoms that it's not supposed to, or if it generates an outcome like excessive recruitment of an inappropriate muscle group to compensate for a weakness, I need that feedback. And I try to provide as much education to the patients to give them ideas as to, okay, this exercise is supposed to generate this type of relief. This stretch is supposed to be felt in this area. If you're getting any of these symptoms, it's not supposed to happen. You need to discontinue that exercise. Give us the feedback that we need so we can make it more patient specific. So I would say the characteristic that I think bodes well for most patients with me is the comfort and openness to be, to communicate how they're feeling through their treatment plans. So I love it when patients are emailing me, letting me know, hey, this exercise is not for me. Hey, I think there's something that could be done that's a little bit more effective. Or, hey, listen, I'm just not motivated to do this exercise plan. It doesn't seem like it's relevant to what I want to accomplish in my active rehab goals. I need something different, because that way I can make things more patient specific. And if it's an exercise that's effective and meaningful to somebody, they're going to be more likely to do it.
Cool. So do your patients have like a single outcome that they're looking for when they come see you?
It starts that way most of the time. You can go, I imagine you could probably go across a lot of different physiotherapists. I'd say just clinicians in general, family doctors, chiros, massage therapists. I imagine the typical orthopedic patient, I'll say, will come in with, let's take maybe a 16-year-old soccer player who, stepped in a rut, twisted their ankle, and you ask them, okay, so what would you like to do? Well, that individual might start off with something along the lines of, well, I want this pain to go away. Or, maybe it's, I want to get back to playing my sport in 2 weeks because we got a big championship game coming up. Two really different goals there, and two I would say you have two ends of the spectrum there. Okay, I just want my pain to go away. All right, I'm hearing you. Fair enough. And then I want to get back to playing my full sport after I twisted my ankle in 2 weeks. So the next steps of that conversation would be, okay, we need to make that pain goal a little bit more specific. So usually what I'll prompt the patient to do to kind of open them up a little bit more and get more information from them is I'll usually ask them, if I take away that pain, what's the first thing you anticipate is going to be easier or more tolerated in your life, whether it's daily or sport related? Well, I'll be able to walk without pain. That's a great start for somebody who has to get back to a running sport. That's a nice short-term goal. Or if we have somebody who's more advanced, or who's looking a little bit more in the future, like, hey, I just want to get back to my sport in 2 weeks. Well, after our initial assessment, it looks like you have a grade 2 ATFL sprain, and you might need to progress to that in a more realistic timeline, like maybe somewhere along the lines of 4 to 6 weeks, depending on your pain level, depending on the number of fibers that were torn in that ligament in particular, how well you're tolerating certain activities. So how we can take that big goal and break it up into multiple medium-term and short-term goals that are appropriate for that individual. And then if you work your way back to that pain, it's okay, that's a wonderful metric, but how are we going to apply that to something that's specific and measurable? We could always go with a numeric pain rating scale, which is valid and useful, like say, for instance, during a treatment session. But just because I bring a soccer player's pain down to maybe from an 8 out of 10 to a 4 out of 10 does not necessarily mean that's going to translate to them being able to run for 90 minutes straight.
Okay. And when are you typically sort of setting these goals or having these goal conversations?
Short-term goals, I always try to give them something to work off of to show them that there is some piece of subjective or objective evidence that we're heading in the right direction day one.
Day one, okay.
If it's a more basic orthopedic condition like the one I just outlined, it's usually, okay, can we maybe do 5 calf presses on that left ankle that you just twisted at the start of the assessment, where we're trying to be a little bit more provocative or a little bit more trying to dig at the nitty-gritty as to what's happening? Maybe we're not getting it. But perhaps maybe if it's maybe been 3 weeks down the line already, the inflammatory phase is gone, they're in their subacute phase, the pain's coming down, the inflammation's coming down. What if we just gave that ankle a little bit more range of motion? Let's do some stretching. Do 5 sets of that. Now try your calf presses. Oh, wow, that actually feels much better. Okay, that's when I give them the impression, now that was done in maybe 15 to 20 minutes. Imagine doing that 15 to 20 minutes every single day and where you think you'll be able to get to from there. And then also on day one, I like to try to have some type of functional or activity specific goal. We have, the kind of minutia and the elemental building blocks. So we got pain reduction, range of motion gains, strength gains, etc., that then allow someone to go towards something like an activity specific goal. So using the ICF model of kind of diagnosing or kind of approaching a patient, you have your body structures and functions, then you got your activity, and then you got your participation. So for this patient, we would have strength, pain, range of motion in that body structure function. We would have maybe a couple of calf presses, or walking for maybe 50 meters would be your activity goal. And then participation would be more contextualizing all of those into a soccer game, because that's their role as a soccer player or as an athlete.
Okay. And do you find that some of your patients are frustrated or can't perceive their own progress?
Oh yeah, that's really common. It's really common, and it's really common, I would say, unfortunately, in those who have more chronic pain, I would say. Now, I'm willing to hear, I'm just an N of one. I'm more than happy to hear a lot of other clinicians who probably have way more experience than I do, working with acute injuries, working with chronic pain. I think that the population that I see the most frustration with, okay, I've been getting physiotherapy, osteopathy, chiro. I've been seeing my doctor. I've been referred to a pain specialist or a pain clinic. It's been 3-4 years, and I'm still having trouble with, say for instance, working at my desk for 45 minutes, or, I'm still working modified duties at the warehouse, or I can only tolerate driving my truck for, 30 to 45 minutes when, I'm supposed to be driving somewhere along the lines of like 1 to 2 hours straight in a day because I'm running deliveries and I'm self-employed. So I find it's a lot more common to have that report in patients that have chronic pain. With the acute phases, I feel like there's a little bit more variation there, because it depends on the injury, it depends on the individual's pain tolerances and their current goals.
So if we think about maybe the more complicated cases versus your sports injury patient who, tends to have pretty reasonable outcomes anyway, probably not as necessary for us to use any sort of treatment outcome measurement systems. Do you have any sort of, like, with your more complicated, like the kind of description that you had there, the self-employed driver, are the treatment outcome measures that you like to utilize with that population? So now I'm trying to get so we've sort of talked around a little bit, and you have mentioned a couple, but maybe now I'm kind of looking at some specifics.
Yeah. Okay. So I can give you a couple of specifics. I think that this one, I think it's a little bit more appropriate to talk about some people that I use, or some patient populations that I typically use more outcome measures with.
Yeah, exactly.
So typically what I'm going with are I'll bring up two different populations in the last few months. My stroke, my patients who have had strokes, and my patients who have been diagnosed with some type of neurodegenerative issue like Parkinson's.
Okay. All right.
So looking at that, is there any specific outcome measures that you're curious of, or is it just typically what context I usually
it's sort of now that you're talking about that population, I do have a little bit more insight into what now is the treatment that you're providing there. Is that the PONS that you were mentioning earlier? Is that the treatment methodology you're using for that population?
That's one, but I would and that's where there's a little bit more extensive. That'd be a great population to focus in on, those who are kind of currently going through their PONS treatment, because there's a lot more consistency part of those protocols in terms of outcome measurement and tracking.
Okay, well, let's save that one then, because I'm a little more familiar with that one. So let's save that guy.
Okay.
Or I meant by guy, I just mean that sort of population. And let's go where you were going to go. So just tell me about the sort of non-PONS, quote unquote, either the Parkinson's or the stroke patient. Like when would you be implementing these outcome measures, and which ones do you like to utilize, and what kind of information are they giving you back?
I think one of my favorite outcome measures to look at, just general community mobility and functional mobility and balance, including gait, would be the Community Balance and Mobility Scale.
Okay.
That's one of my favorites. For individuals who have a little more independence with their mobility, who typically don't require the daily use of a gait aid. And that would go across both people who've had strokes and people who've been diagnosed with Parkinson's. So what I like about, so let me just start with answering the first part of your question. So when would I start implementing that? Day one.
Okay.
Day one or week one. So if I'm trying to get a read, let's say, for instance, a neurologist or a family doctor has referred one of their patients to me for balance and gait rehabilitation or training, and their diagnosis is Parkinson's or Parkinsonism. I will try to start with getting a good subjective history, get a good past medical history day one. If there's time, I'll try to do part of the Community Balance and Mobility Scale and try to focus on the items that are a little bit more immediately impactful. So let's take one of my patients, for example, who was diagnosed with Parkinson's. He was diagnosed, I want to say 6 years ago, and was referred to me about 2 years ago for, I don't want to use the term late stage, but I would say mid to late stage Parkinsonism. So his main issues were he was a high risk of falling, he had a lot of gait instability, and he didn't have very good limits of support with his static position. So the Community Balance and Mobility Scale takes into account static stances with tandem balance. It takes into account your ability to maneuver your body outside your base of support, within your base of support. It requires you to engage in different functional movements like weight shifting, offloading, or loading limbs to engage in swing. And then it has other more advanced gait practices like, walking while picking something up off the ground, walking using crossovers, doing single leg activities like scooting on your heel, or just simply standing in a static position in a less supported position than you typically would.
Does it have like a scoring?
Oh yeah, it's got
a scoring system with it. Is it like a single digit that you get at the end, or what kind of score do you get at the end?
I'll usually get, depending on the stage of the diagnosis for Parkinson's, I'll usually get somewhere in like the low double digits, depending on the individual.
And then does the score itself, like, are there ranges of scores that say 1 to 4 equals this and 5 to 10 equal that, or do they just kind of give you like a single score and you're just kind of showing your patient you've gone from a 6 to a 9 or whatever?
So, I mean, you can dive in, and I do like to try to, I mean, I try not to dive into the normative data because across the outcome measures, granted, I haven't looked into the recent literature into the CB&M that's come out in the last 5 years, but a lot of normative data is fairly old. And I don't, just me personally and professionally, I don't like comparing my patients to the normative. I like to kind of show them where they're at right now, what each of these items kind of identifies, how our treatment plan can address these individual items and what it means practically in terms of function. So if somebody, say for instance, does the CB&M, I'll use that for short, and is having difficulties with step ups. Okay, we look at that score. Let's say, for instance, they scored in tandem stance or tandem walking, yeah, we'll do tandem walking. They scored 3 out of 4. Okay, great. But then when you look at the step ups, maybe they scored a 1 or a 2. What's the difference between those two? How are they similar? How are they different? Well, let's just talk about gait in general. What are the necessary components for a tandem walk versus, say, for instance, a shift in step? This is all just for an example. Can the person actually shift their weight? Does that person have proper core engagement? That's where I would take that outcome measure and I would go back into my just objective clinical assessment and do targeted muscle specific or functional specific testing to see, okay, can they take their core, can they engage their core properly, and can they translate their weight from hip to hip as opposed to foot to foot? Well, if they can't do hip to hip properly without losing their balance, tipping their shoulders down, they're not righting laterally, they're actually side flexing. That might be translating into postural instabilities in a gait position. Or if they do just fine with lateral righting where they can shift their weight from glute to glute, is there some type of ankle proprioceptive issue? Do we need to look at their ankle, their calf range of motion, their calf strength, etc.? Try to with those specific outcome measures. And then, so that's how I go back into the specifics and how I can kind of prescribe exercise. But okay, well then what else can you use those outcome measures for just in terms of analyzing the numbers? You can go into the normative data and just make a judgment in your analysis. Okay, what is this person currently categorized as? Either like low functioning, moderate function, and then high functioning. But then say, for instance, depending on the diagnosis and contextualizing it, what are your goals? Are your goals remediative? Or are you looking to remediate certain things like balance and gait, trying to actually improve them? Are you trying to maintain them and mitigate regression with certain individuals? And you make sure you have that discussion with the patient too. It's okay, not only what is this outcome measure and what does it measure, but what are we going to use it for?
And do you find that your patients, do they like these treatment outcome measures that you're using? Is that like, are you finding it's like, I think at the very beginning, I really love the fact that you said, I want them to communicate with me. Is this a good communication vehicle for you guys?
I think it depends on the individual. I think that certain individuals don't respond very well to numbers and being part of ranges.
Okay.
I think that for some individuals, maybe perhaps there's other psychosocial factors at play. Maybe it's demotivating to start and I just start with general functional goals, or maybe I try a different outcome measure. Not to give them the wrong impression and give them a ceiling effect, to give them the impression that, things aren't, as bad as they seem. I try to give the appropriate outcome measure based on their functional levels and then try to frame it in a way of, okay, at least worst case scenario, we've identified areas where we can improve and where we can definitely realistically address these impairments or restrictions within the physiotherapy scope of practice. But to kind of come back to what you're mentioning, how do they respond? I think those who respond well are those who understand the nature of the outcome measure and how it's being used. So I think a big part of that falls on the clinician as well, not to just turn their patient into a number, but to actually get the patient to understand what the number means, why it's important to them, and how it's actually going to give them evidence that physiotherapy or some type of therapy is actually doing something for them. Because as great as it is to see those numbers go up, a patient might look at me and I say, okay, well, you know what? Let's take let's switch to another one just because there's actual cutoff measures for this one. The Berg Balance Scale. Okay, let's say they got a 41 out of 56. Well, you're below the cutoff score that would be indicative that you're a high risk of falling.
Okay.
It's statistically validated to measure that. So if we move above 45, that patient just became a 48. And I'm noticing just on observation that they're doing much better. They're a lot more confident. They're less unstable with their static balance and their gait. Now you can look at that, and that gives them there's a little bit of a positive reinforcement there. But say, for instance, if you're in the community balance mobility scale, well, I just went from let's use the same numbers. We went from, say, for instance, a 42 to a 48 out of 96. Okay, well, different denominator for sure. Take that as you will. But what do those numbers mean? That's where you get into the chats about, what's the minimal detectable change versus the clinically meaningful change. And then outside of that, what's actually meaningful to the patient. I think that comes from a bit more understanding and knowledge about the outcome measure itself.
Okay, excellent. So I'm curious to hear your thoughts on I don't think everybody's familiar with the PONS, and I'd be curious to hear your thoughts on, just maybe you want to give our audience a quick description of what it is, what it's supposed to do, how you guys are utilizing it in your application, and then we can kind of finish with the sort of treatment outcome measures that you're doing associated with the PONS treatment.
Yeah, for sure. To be fair, first thing I'll say is I'm probably not the best person to ask about this, but I'll give you the quick and dirty on just what the PONS.
You know what? Like with everything, we're just here to get people's opinions and just kind of get different viewpoints on things, right?
Yeah. So the PONS device, was developed by by a company called Helios, and I believe it was initially to help patients who would be considered in the mild traumatic brain injury population. And then there's been studies ongoing to see whether or not there's other applications to brain injuries, acquired brain injuries, including stroke. I was actually, hilariously enough, doing a scoping review under Dr. Julie Von Graham and Dr. Dina Brooks at McMaster University about the PONS technology itself. And there's a whole bunch of interesting gray literature out there about the different populations that may potentially benefit from it. But if I was to do an elevator pitch for it, basically what it is it's a tongue stimulator that generates action potentials from the 12th cranial nerve in your tongue to your brain stem. And it basically, if neuroplasticity or neuroplastic change that we expect or try to generate after a brain injury is the product that we're trying to build, the PONS device is like fertilizer to the soil. It primes the soil to grow the crops, and in this case, it primes the brainstem and the central nervous system to engage in neuroplastic change. So you take a regular physiotherapy session for somebody who's had a stroke. What are we trying to do? We are trying to get somebody to activate areas surrounding the area of injury from the brain, or the part of the brain where there was a lack of blood flow because of an aneurysm, or because there was a bleed, or because there was a blood clot. And we're trying to get those surrounding areas to compensate and change their pattern to support the areas that were lost. The PONS device makes that, from a hypothetical and a practical standpoint, tries to make that a little bit more effective, that process of getting neuroplastic change from different areas of the brain to support those areas that have been impacted.
And so, like on a really practical session, like what does that actually look like? Does the patient sit down and stick this in their mouth for like a couple of hours, or like what how does that actually look when your patient arrives at your clinic?
I'm sure if you asked a lot of my patients during my sessions, it probably feels like hours to them, because it is a pretty intensive training program. So what we do is we give them a little bit of education. We show them how to properly use the device, clean the device, etc. It sits on the anterior 2/3 of the tongue, and we engage in balance and gait exercises in addition to breathing and awareness training exercises. So what we try to do is we get the device on while the device is delivering signals to the tongue, delivering stimulation to the nerves. We have them performing standing exercises like feet together, eyes open, eyes closed. Can you reach to grab this object to your left? Can you turn your head to engage in a little bit of postural perturbations to maintain your upright balance? We then switch, then that's usually done for 20 minutes. And then after that, another 20-minute session with a fresh PONS device, or a fresh session for the PONS device they're using. We'll do gait. So we'll have them walking. I'll have my patients do side stepping. I'll have them do backward stepping. I'll have them using our ladder training devices. So we'll floor ladder, do high stepping, do high side stepping. I think the more interesting activities that I'll have my patients doing is maybe putting them on balance boards for more higher functioning. So actually changing the environment around them to see how they respond to it, and then getting all the different systems, whether it's visual, muscular. For some who are a little bit more independent with their mobility, I'll even do some vestibular exercises with them. So have them changing their position in standing, having them change their position while they're walking to engage the vestibular systems a little bit more.
And like with all that activity, is there like a fatigue component? Like are these patients more more fatigued because they're like, quote unquote learning more, or like have you seen any sort of association with that?
Oh, 100%.
Okay.
I mean, just right off the hop, having that central neurological fatigue and peripheral neurological fatigue, and in addition to potentially orthopedic issues that have come from the different neurological impairments, you're dealing with quite a bit of fatigue. That's one factor that I feel like puts the greatest responsibility on both the patients and the treating and assessing clinicians to adapt training protocols so that you still hit those 10 fundamental principles of neurorehabilitation. One of them being duration of the activity, and then more importantly, which I think the PONS protocol does a really good job at hitting, that it's probably the most difficult, in my opinion, to hit during any training session with somebody who's had a stroke or a brain injury, is the intensity. Because usually, depending on the individual, a lower tolerance because there's so much more fatigue involved in that. So just think about if I had you sit down until your right leg fell asleep and then asked you to go up and go for a walk. But if we just kept that feeling of that leg falling asleep, you kept that feeling. Or maybe if I asked you to do 200 squats and you just felt that lactic acid burning, imagine that setting in at about minutes 2 or 3, but you got to walk for 20 minutes. That's a big factor in kind of managing the actual sessions to keep the duration, keep the intensity, and make sure that the training session is patient specific.
And then within that PONS context, is there some of the treatment outcome measures within there that you find have been better reflective? Are they all great treatment outcome measures? Like, what are your kind of thoughts about the ones that, because they're standardized, as I understand it? Yeah.
Yep. So I do think that there's a lot of really good outcome measures that are being used. Off the top of my head, I do like the Berg Balance Scale, although there's been a couple of individuals in both the in the study protocol that we're doing right now that max that out.
Okay.
So what's nice is that they offer a diverse selection of outcome measures. So you have Berg Balance, you have Functional Gait Assessment, you have the Dynamic Gait Index. The more I would say time consuming and I would say all encompassing assessment tool that they use for the protocol is the FMA, the Fugl-Meyer assessment tool. They offer you the ability to engage in the upper extremity, but we, or at least I, tend to stick more to the lower extremity because that's what the PONS protocol is more targeting. But they give you the option to. And then for our private PONS users or our private cases that have PONS devices, I did my first assessment for that 2-3 weeks ago. That I was really happy with because I was doing somebody's week 8 assessment, and the initially treating and assessing physiotherapist who was just out of town, she had 4 different subjective outcome measures, which were, diagnosis specific. So that patient didn't have a stroke, but had another neurological condition. There was subjective outcome measures that the PONS protocol offered that were a little bit more diagnosis specific, individual specific. And then it allowed us to scale the different outcome measures. So say, for instance, on week 1, she was below the cutoff for the risk of falling with the Berg, but then by week 8, she had already maxed out. So my colleague had advanced her to the Community Balance and Mobility Scale. And then we used that as a measurement tool too. So I think that with those particular patients, I think that they're usually the most sensitive to the outcome measures in terms of just how they respond and the numbers that we can measure for positive change. And there's a lot more flexibility with it. So I actually, within the PONS, I actually really appreciate the use and the kind of the way that those outcome measures can apply to a general population like that.
Hmm. I guess since your exposure to the sort of PONS treatment outcomes, have you sort of relooked at the way that you're looking at other populations, like the way that you would utilize treatment outcome measures with other populations?
I think it's definitely, I'll say this, when I first started practicing, one piece of advice that I got from my last placement preceptor in my McMaster schooling was beware outcome measures. And I get why. You don't want to relegate somebody to a number. But as I just said before, outlining just kind of contextualizing the person and contextualizing what you're using that outcome measure for, they can actually be very motivating, and they can demonstrate objective clinical improvements, and they can be very beneficial in terms of establishing treatment plan goals and determining prognosis for recovery, whether it's just functional recovery, being able to get in your car without needing to use your walker, or if it's being able to walk for 100 meters with your walker. I think that study and those populations in particular have really kind of opened my eyes to being a little bit more conscientious and a little bit more aware of how outcome measures can actually be beneficial to measuring change and measuring positive change.
Great. Well, I think I'd like to sort of wrap up our conversation. This sort of half an hour or more has already gone very, very quickly. It's been a real joy to listen to you pontificate about the treatment outcome measures. It's been eye-opening for me. So my takeaways, and you can kind of let me know if you think I've got this correct. We should be leery of treatment outcome measures, meaning we shouldn't just slap them on the table and have the patient fill them out and then stick a label on our patient after they've completed them. Having said that, we can utilize these as a communication vehicle to help us understand our patient and maybe help our patient understand themselves and their progress throughout, and that they can be useful in both, subjective and an objective placement for maybe translating people from just thinking about their pain to thinking about how they're functioning in the world and kind of guiding them along that path way. But we, at the end of the day, I think what you're telling me is that we should always be thinking about the patient and how they're going to react to the information that we're giving them. Is that sort of a reasonable summary of how you're perceiving those treatment outcome measures?
Yeah, I would say that's more than fair. Yeah.
Okay. Is there anything else you would like to give us before we call it a day today?
In particular about outcome measures?
Anything we didn't cover that you kind of thought we might talk about? Or
I would say no, I actually like that. Just going over kind of like the nature of what is an outcome measure, how can we use it, how can we make it patient specific, and how can we actually generate meaning from it. That's the whole, there's your hook, line, and sinker right there, just in terms of engaging in ethical and patient specific and evidence-based practice. Like, these are statistically validated tools to, whether it's a diagnostic tool to identify a certain population or to identify a certain risk, whether it's to categorize somebody within a level of support, whether it's to measure change or measure status within a given activity base or within a kind of more general parameter like gait or balance. I think that it's really useful as an evidence-based practitioner. You want to make sure you're actually engaging with what the scientific literature indicates is going to be beneficial. And it's also nice to kind of make sure that you keep your wits about you, because every day there's more science coming out. Every day there's going to be more outcome measures. Like, you see a lot of different diagnostic tools coming out with different versions almost every year. So I would say that it's beneficial for clinicians to keep up to date with the scientific literature. I think it's beneficial for patients to give them some type of motivation, or at least give them that whole kind of general principle that we hear all the time with, whether it's personal training or rehab. you got to know where you're starting sometimes in order to figure out where you're going to build a direction. And the one thing that I've learned over the last 3 years is that some direction is better than no direction. So if you're not entirely confident working with outcome measures, I think that a good place to start would just be kind of go into the literature, go and see what's out there, think about what you're familiar with, what different treatment platforms have provided you, or different kind of models of care have provided you, and what they use in terms of outcome measures, and then ask yourself why that is. Like, don't just write off outcome measures right off the hop because, I want to look at the patient and see what their specific goals are, which is great, and you should do that, but also think about why somebody else has done that. For my students, I always tell them, okay, think about why I'm doing that. Oh, somebody used this outcome measure in this specific context. Okay, why did that work? Ask the question why before you just come up with the conclusion whether or not an outcome measure is appropriate or not appropriate. Just why am I not including the outcome measure? Why would I include an outcome measure?